ejaculation, there is a device which is put under rectum, under supervision. It's a surgeon who does it, and we stimulate the nerve, because in spinal cord injury, usually the nerve which causes erection and ejaculation, that is paralyzed. So we go and stimulate it electrically in a controlled pattern way, and that causes ejaculation. So we collect the sperm then, and then with that sperm we wash it and we perform an IUI.
We proceed. Would you kindly introduce yourself?
Okay. So I'm Dr. Ashima Sarkhel. I'm a gynecologist. I'm currently working in reproductive rehabilitation of disabled patients to start with spinal cord injury. Just this much.
Where exactly?
You want me to go for qualifications?
No, no
Okay.
qualification needed, but basically where you are from, where exactly in Orissa?
Okay, I'm from Pippili. It's a rural area which comes under Puri district of Orissa.
Okay.
It's a small village consisting of around, right now where we have around 1,000 to 2,000 population. Small area. We are basically working in a rehab center. We have developed a rehab center here under the trust. We are mostly working towards disabled patients.
Okay. And how long have you been in this field now?
Now, this trust was founded by my husband and me, along with few other members. So in this field, we are currently from 2 years. Okay. Earlier, I was in a central government job and in corporate job. But dedicatedly, this year, we have 2 years completed.
It's commendable to leave a central government job and a corporate job and to open a trust fund.
So we actually wanted to do rehab because that part is lacking in the northeastern and eastern part of India. Much of the rehab centers are there in CMC Vellore, down in South Manipal, or towards Chandigarh or Delhi, Lucknow, Mumbai, APMR. So this side, eastern and northeastern side of India, this part is lacking. So we have been in this part. We wanted to develop this for long ago. Since 5 years, the planning was there. So for last 2 years, we are able to make the hospital. It's basically a hospital of 15 bedded, currently extending into 30 bedded in next 2 months. So we basically deals with all disabled patients, all kind of disabilities, deformities. So for me as a gynecologist, I'm more concerned towards their reproductive rehabilitation. Once a patient is disabled, whether a brain injury or spinal cord injury, they become infertile. Although they are not basically sterile, but they are infertile. To look on that part, so I don't do general infertility. I usually do most of disabled person's infertility management.
Right. And you get your patients from where?
All over India. We have our patient all over. We have local patient also. We have all over India patients coming. Usually most of them come for their spinal cord injury. Patient comes for their bladder management, or main is pressure ulcer. Most of them having more of pressure ulcers. So they usually come us from them. And then once the pressure ulcers are treated, then we go for their rehabilitation. The first stage of rehabilitation is to bring them back to the society. Making them independent for their own daily activity. The second phase come making them occupationally rehabilitating them, giving them jobs or training them with jobs which they can do once they go back to their society. Or if they are in government jobs or somewhere facing problems with their disability and not able to do the job or something, to making adjustment in their office, or having little talk with their office how to rehabilitate, occupationally rehab them. And the third one comes how to make them reproductive, basically sexual rehabilitation. And if they need reproduction, if the guy is recently married, not having children, then we go for reproductive rehabilitation. Otherwise, sexual rehabilitation we usually do. The 3 main rehabilitation we do with them. So we have our own network because my husband is a PMR specialist. He's a disabled surgeon. He's one of the members of the Central Government Disability Board. So we have been working with Spinal Cord Injury Society of India, regularly in touch. So they also provide us with all this kind of patients.
Right. And the trust name is The Trust?
The Trust, THEE. Yeah, it's The Trust. Meaning being your trust. This
Yes,
is dedicated to the patients.
yes. And I see that you offer services which are at a minimal cost.
Yeah, we do that. That was the main object of our trust, was to provide quality services, but at a cheaper rate, which patient can afford. And most of the disabled patient, if we see when they have that acute trauma, you are going. So most of the rehabilitation costs in lakhs. It happens in lakhs. When the patient is had a bike accident and then paralyzed downwards, most of the family will keep on trying different kinds of methods to save the guy or make him walk. So our work comes when they lose hopes. Once they know that this guy is not going to walk, he will be bonded to wheelchair. From there we take him. Because till then they keep on losing money, going here, going there. Maybe we can walk, maybe. So most of them, till that stage comes, when they are in the stage like, okay, I know now I can't walk. Till then they must have definitely lost a lots in lakhs. And then there is a stage where now they have to live whole life in this wheelchair. From there we need to take. So if we make them very costly for them, it they give up. The family supports also is not there. So that's the reason we started it. So that they, at least once they start rehabilitating, once they start go back and having their own job, they are self-sufficient. So usually what we do is, I'll just say, if they're here for 3 months, so per day, everything including medicine, if we need surgery because of pressure ulcer, we need to do flap surgery at times, reconstructive flap surgeries. Everything, they usually cost around 1,000 per day. So the total cost of 3 months, 90 days will be around 90 days with surgery, with medicine, with the patient and relatives staying here with food, everything. So more or less this what it goes. And if we can get a donation for that person, if he has his disability cards and income certificate, so we do provide donation for them, at times full free surgeries also.
Okay. So this is extensive work. What if the patients come to you directly after the accident or after they are wheelchair bound?
So, ma'am, see, acute stage we usually don't take, because acute stage at times may needs ICU. So we don't have an ICU backup right now with us. We are planning to have it, but since it's very new, so acute stage is usually managed by a neurologist, because first 3 months of any accident, brain injury or spinal cord, they are multiple problems where the patient can have other things and ICU can be needed. So once the patient is stabilized, then we take.
And after that, after they're stabilized, you approach the problem holistically, because I see you give placements also, skill training.
Yeah, that's basically we have to treat him, because he has to go back to the society. He's have to leave there. So we have to give him whole stick. Just treating his injury or just treating his bed sores, because that is very common. Spinal cord injury and having big bed sores. This is very common, and the most common cause of deaths in spinal cord injury or brain injury patients. First is spinal cord. First is pressure ulcer. Second is the bladder problem. These two are the main causes. So we need to treat that pressure ulcer. So first we do that, make their life stable, and then we go for other things. So most of them will around take 1.5 months to 3 months. So they usually stay with us for around 3 months.
In house alone or with as a couple sometimes?
Usually they have one relative. That's the mandatory law by Indian government, that you need to have one attendant with the patient. You can't have the patient alone. Still that law is there in India, because anything goes wrong, that there will be someone to sign or give consent. So that is, so if the wife wants to stay, she can stay with us, or if the mother or father, whoever is there, usually they stay with them.
Am I right in assuming, ma'am, that you also give counseling?
Yes, we also give counseling. Yeah.
Right. I want to come to the reproductive rehabilitation that you mentioned. How do you go about it?
The major reproductive rehabilitation, we have divided into one fertility treatment and the second in sexual part. So sexual rehab, we teach them other methods, how they can have their normal intercourse. We have our methods, and we have penile prosthesis and other things, devices which they can use, because most of the spinal cord injury patients have the problem lies only in the erection and erectile dysfunction. Their sperms are usually normal. So the problem with them is they are unable, their penis erectile dysfunction and this. So we first ask them if this, do you want to go for infertility? Do you want to fatherhood? Want for a fatherhood, or you are just for your sexual? So that's how we manage. But sexual path is different. My role comes more when it is in they want fertility treatment. So most of them we use PSV, that is penile vibration stimulation program, which is the protocol is basically followed from Miami, Florida Institutes of Disability. They do it. They were the one who done it under Dr. Ibrahim. So that's the protocol we form. And if it doesn't work, then we go for electroejaculation, take the sperm out, and with IUI we do it.
What?
We don't go for IUI. Yeah, ma'am.
What exactly is electroejaculation?
Sorry. Electroejaculation, there's a device which is put under rectum, under supervision. It's a surgeon who does it, and we stimulate the nerve, because in spinal cord injury, usually the nerve which causes erection and ejaculation, that is paralyzed. So we go and stimulate it electrically in a controlled pattern way, and that causes ejaculation. So we collect the sperm then, and then with that sperm we wash it and we perform an IUI.
So this is where Subhak Health Tech products such as Underwash will come in handy.
Yeah, that's the reason why. Because see, most of our what is happening, most of our patients are either they're wheelchair bounded, few of them are tetraplegic, so they are bed bounded. So to make them daily come to the lab, go away, go and because we stay in a village area. Right. So we haven't developed full IVF center here. So earlier when we started, we had a tie-up with an IVF center in Bhubaneswar. But to send them there and then again bring them back, at times they can't ejaculate that day. So we have to abandon the procedure that day and again do it. So it was costing a lot of inconvenience to them. Even the expense increases, transport expenses increases, and it becomes very inconvenience, and they are not comfortable at times in normal laboratories, because they are not normal IVF centers are not very good in dealing with spinal cord injuries, erectile dysfunction. So what we planned, like we wanted something which we can start in a small, which can be handy, which can be movable, portable kind of thing, which you can take to their personal room, private rooms, or within few minutes. It should be like I can ask them just to come from their ward till my room. So that becomes very handy. So that's how I first got to know about Andro Wash via Facebook, I'll say. In the Facebook first I saw it. I didn't have any idea that it is going on like this. And then from that I contacted Rajat, and that's how I know. So I think we liked it very much. That's how we started it. So I haven't used it yet, but I think this is very convenient for us. That's the reason we even have brought the sperm analyzer, small one, SQI, from the Israel company, that small one. So that is portable. You can take it to the patient's room and do it. Because they need bigger space, because they are using wheelchair, or usually the collection should be like that. That is disability friendly. It can't be for a normal person. It should be disability friendly. That room should where they will ejaculate. So we need to change the room. So we have that. So we just needed something which is portable, so we can use it. In that case, I think EndoWash is great help for us.
You mentioned disability friendly room. What exactly does the room look like for a layperson like me?
Usually disability friendly rooms are the switches or the chairs and all, they are like that, or the table are which the wheelchair patient can access. See, they are on wheelchair, they keep on rolling. So you have to give them, if you give them a table or collection area which is narrow, where they can't go, or they can't use the washroom, because most of the spinal cord injury patients do ICC. That's how they manage their bladder. ICC is intermittent clean catheterization. Every 4 minutes, like normal person, when we feel urine, we go and urinate in the bathroom. For spinal cord injury patient, they can't feel urination. We have to train them that every 4 to 6 hours, they'll go to the bathroom. They have a kit with them. They have a police with them. they have to insert it through their penis and take the urine out and then come out. That's their routine. All whole life they have to do that. Like we go to washroom, they go to. So that washroom and all should be disability friendly. So the your wheelchair can go there, it can rotate back and come. Then you should have side railing where they can hold it, stabilize their body, because their trunk doesn't have much control, right? Depending on the level. So that, and then there should be that slope. There should not be abrupt steps because the wheelchair won't go. So this all are the techniques. Means we have to look towards disability friendly room. The switch, the fan switch and all should be at that level where while they're sitting in the wheelchair, they can switch on or switch off. The level should be like that. So that's